Have you ever heard the term isthmic spondylolisthesis? Yeah, it's a real mouthful, I know. But if you or somebody you love is dealing with that nagging, persistent low back pain, this is a name you're going to want to understand. Basically, it describes a very specific, kind of weird thing where one of the bones in your spine slips forward. So, okay, let's just dive right in and make some sense of this. For this whole breakdown, we're not messing around. We're going straight to the top, to the experts. Our guide here is an official clinical guideline from the North American Spine Society. Now, this isn't just someone's opinion. It's built by reviewing all the best scientific studies out there. So what we're getting is the real deal, just the evidence.
So here's the plan. First, we'll explain what this slipping spine thing even is. Then, we're going to learn how to decode the medical evidence. And trust me, this is the key to everything. After that, we'll hit diagnosis, check out the non-surgical treatments, talk about when surgery comes into play, and then wrap it all up with what this means for you and your doctor.
All right, first things first. Let's get down to the basics. What in the world is a slipping spine and who usually gets it?
Okay, let's just tackle that ridiculously long name head on. In plain English, what is it? I want you to picture your spine like a stack of Jenga blocks, right? One on top of the other. Now, imagine a tiny little crack develops in the back part of one of those blocks. That crack, in the little spot called the pars interarticularis, can actually weaken the whole block, and that lets it slip forward over the one below it. That forward slip, that's isthmic spondylolisthesis. And you know, those little fractures, they're actually more common than you might think. But here's the really important connection. When those tiny cracks happen on both sides of that bone, the guideline says that a whole lot of people, we're talking between 40 and 66%, will end up with that forward slip. Okay, now we're at what I think is the most powerful part of this whole explainer. Because if you really want to understand your treatment options, you first have to understand how doctors think about the evidence behind those options. It's such a simple idea, but it's absolutely crucial. Some treatments are backed by huge, really well-done studies. Others, well, the science isn't as solid. The North American Spine Society uses this really clear system to grade the evidence, which is super helpful. And here it is. This is the Dakota ring. Grade A is the best of the best. It means something is officially recommended. Grade B is pretty good. It's suggested. Grade C means it may be an option, but the evidence is kind of weak. And then you have grade I, which means the science just isn't there yet, so its benefit is uncertain. Burn this key into your brain because we're going to be using it a lot. Okay, so let's take our new evidence decoder for a spin. We'll start with how this thing is diagnosed. What are the signs, and how sure are we about them? So if you have this condition, what would you actually be feeling? What are the classic tells? So the guideline points to two main symptoms. First, no surprise, is low back pain. The second one is something called radicular pain. That's just the fancy medical term for pain that shoots down from your back into your leg. You've probably heard it called sciatica. And check it out. The evidence that connects this condition to those two symptoms gets a grade B. That means it's based on fair evidence. Doctors can suggest these are the classic signs. So what this really tells us is, we're pretty confident about these symptoms, but it's not 100% slam dunk for every single person. Symptoms can point you in the right direction, but to know for sure, doctors need to actually see what's going on in there. So which scans give the clearest picture? Man, this chart just lays it all out so perfectly. An MRI gets a grade B, so it's suggested for seeing if that slip is pinching any nerves. But a CT scan, it only gets a grade C, maybe an option, for actually seeing the little bone fracture itself. And discography? Grade I. The evidence just isn't there to say one way or the other. See how useful this grading is? Okay, so you've got the diagnosis. Now what? Let's talk about non-surgical treatments first. And this is where the guideline had one of its most, well, surprising takeaways. Right, so we're talking about all the usual suspects here, the common first-line stuff. Pills, steroid shots to calm things down, maybe wearing a brace, and of course, physical therapy and exercise. So what does the best science we have say about how well these work for this specific condition? And here it is, the big reveal. For all of those common treatments, the guideline found grade 1 or insufficient evidence. Now, this is really important. It does not mean they don't work. Lots of people get relief from these things. What it means is that right now, we just don't have enough top-tier scientific studies to prove it. So the experts can't make a strong official recommendation.
So, if the evidence for a lot of the non-surgical stuff is kind of murky, where do we find some solid ground? Well, that brings us to surgery. For some patients, this is where the science gets a whole lot clearer. So, when the other options just haven't cut it and the pain is really impacting your life, surgery can get put on the table. So, what are the options that have the strongest scientific thumbs up? Boom! This is where we finally see that grade A. The evidence is strong, really strong, that both of the main types of spinal fusion surgery are recommended to help patients feel and function better. It doesn't matter if it's a fusion just from the back or a 360-degree one from the front and back. The top-level evidence says they help. But then you get this, which I think is a fantastic example of just how honest science is. Even with grade A proof that both surgeries work, the guideline comes right out and says the evidence is conflicting, basically grade I, on whether one is actually better than the other. So science tells us, yes, these work, but it also says, we can't yet tell you for sure which one is the absolute best. So we've broken down the problem, we've decoded the evidence, we've looked at the options. What's the big takeaway for you? Well, the real power here is taking this knowledge and using it to totally change the conversation you have with your doctors.
We've seen it pretty clearly, right? Even with the best evidence-based medicine, there are still gray areas, still questions without perfect answers. And that's the whole point. Knowing what the evidence says, and just as important, what it doesn't say, empowers you. It allows you to ask the best questions for your own life, your own body. It lets you change the conversation from, "Doc, what should I do?" to, "Okay, given the evidence we have, what makes the most sense for me and my goals?" And that right there is a total game changer.